Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. And I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
I'm doing great. Thanks, Pete. How are you today?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Okay, so today we have an episode for you on a hot topic in shoulder arthroplasty. In particular, we're going to talk about stemmed and stemless humeral components. And to discuss, I've invited two national experts. So first, from the Mayo Clinic in Minnesota, we have Dr. John Sperling. Dr. Sperling, welcome to the podcast.
Pete and Rachel, thanks so much for the opportunity to be here today with you.
We're so happy to have you. And from Beaumont, Michigan, we have Dr. Michael Wiater. Dr. Wiater, welcome to the podcast.
Thank you, Rachel and Peter. I really appreciate the invitation, and thanks to the ASES for having me. I'm very honored to be here.
Okay, so let's start at the beginning with our go-to workhorse style humeral component historically, which has been the stemmed component. So, Dr. Sperling, tell us, what are the advantages of a stemmed humeral component?
Well, there's no doubt there's a long track record of success with stemmed humeral components. So if we look across the board, the rate of isolated humeral loosening has been extremely uncommon. So there's been a lot of evolution, obviously, from cemented to uncemented designs, and we've gone to shorter and shorter stems. And throughout all of this, thankfully, the rate of loosening has been uncommon.
What are your thoughts, Dr. Wiater? Anything to add?
Well, it's certainly tried and true, and it's familiar to literally every surgeon. So that really goes a long way. It works in any situation, just about, except for a severe malunion of the proximal humerus. So straightforward primary cases do well with stemmed implants, up to the most complicated revisions. So it's a very effective technique, and it has certainly withstood the test of time.
So let's move on to we've heard the good. Let's hear the bad. So, Dr. Wiater, what are the disadvantages? What are the problems we've encountered with stem components?
Well, there are some disadvantages. So it is more invasive than a stemless implant. So you have to remove more bone. It does require at least reaming, if not reaming and broaching the proximal humerus and humeral shaft. So that in a revision situation can lead to diminished bone stock, which can complicate matters. It can create stress shielding. So, depending on the implant design and the sizing and the fixation, you might see resorption of the proximal humerus from stress shielding. And if it does fail for whatever reason, whether it's loose, aseptic loosening, or simply malpositioned or infected, the revisions can become pretty complicated. So, you end up with a situation where you may be you not only compromised in the proximal humerus region, but may have compromised bone stock well down into the shaft of the humerus, which can require some pretty heroic salvage techniques to compensate for that.
Anything you'd add, Dr. Sperling? What do we miss? What are some other downsides of a long stem humeral component?
Yeah, it's really interesting. I think Mike said it very well. I think the challenge, of course, is when we think about revision. There are some stem designs, fully porous-coated designs, some with unusual geometries that can make removing them extraordinarily difficult and can really result in significant destruction of the humerus. We've also recognized that, at least I've seen in my practice, frankly, that humeral component malposition is not that uncommon at the time of revision, particularly with freehand cuts. So when you have malpositioned components that, with stems going down a significant length down the arm, can make removal difficult, particularly setting also of being cemented. So I think the last thing I would say about that, as Mike said very nicely, is stress shielding. As we've known now that there are some certain geometries of stems and perhaps some coatings of certain stems that have been associated with a higher rate of stress shielding and bone resorption, and that also can be concerning.
I would add another disadvantage to the stemmed implant is the risk of an intraoperative fracture. So, over the 20 plus years I've been in practice, I've seen the transition. There were no stem or stemless or short stems back then. Everything was kind of the standard length stem, which was anywhere from 120 to 170 millimeters in length. And many stems, when I was in training and early in practice, were fully cemented. And so we've seen the transition to cementless press fit stems, which in many respects is good. I mean, I think one of the most difficult revisions is trying to explant a well-fixed, fully cemented humeral prosthesis. I mean, you can literally destroy the humerus trying to get a stem like that out. So with a cementless implants, there's a lot of advantages, particularly for revision. But it does have some disadvantages too with a tight press fit. You want to put the implant in stable, so you don't want it to be too loose, so you put it in tight. And if you do enough, stem implants in a press fit fashion, at least once in a while, you're going to crack a humerus. So one of the disadvantages of a stem is the risk of an intraoperative humeral fracture.
So before we move on to stemless, I wanted to chat real briefly about this issue. Because like right now, on the market, there are mostly cementless components. And in the United States, we've moved largely towards cementless humeral components. I know there are other places, specifically in Europe, where people are still largely cementing their primaries, and there's nothing wrong with that. I think the registry data actually supports it. I wanted to ask both of you before we move on to stemless, are there situations in which you still will both, in a primary setting, cement your humeral component? So, Dr. Sperling, do you have some primaries that are still cemented, and if so, who is that patient?
Actually, in my practice, the answer is really none. I haven't cemented a stem on a primary probably in 15 years. What I will tell you that we've learned with stems, and we learned from our hip and knee colleagues here at Mayo, the only time I cement now is I do a cement within cement technique on my revisions. So what we'll do is take 122 stem that's cemented in there, and I'll cement in an 83 millimeter stem, a more narrow, shorter stem. So on the revision side, when we use stems, the goal is to go shorter and shorter, not longer and longer. So we have a lot of revisions here at Mayo that are interesting, where if we pull a 122 stem, I'll put a 55 or 83 millimeter stem in, and there's stem, air, pedestal. So we actually don't bypass that. And I think to Mike's point, we see a number of people that go longer on stems, and to try to put a straight stem in a curved bone, you can fracture it distally. And we've seen that quite a bit. So what we try to do, at least here at Mayo, is to go shorter and shorter, not longer and longer on the revision length stems, which is a little bit different, but it can sure make your life a lot easier if you're going to use a little narrow, short stem on revisions.
What about for you, Dr. Wiater? Are there any stems that you're primarily cementing right now?
I've made it a goal in my career to avoid cement as much as possible. So I quickly abandoned cementing when I got in practice. And, I would kind of echo what John said. I can't think of a primary case that I've cemented in probably 20 years. I do cement occasionally on revisions. And like John said, oftentimes it's a shorter stem. If I explant a cemented stem that's well fixed and not infected, and sometimes you can bang the stem out and leave the cement mantle behind, rather than chip out the cement mantle and spend a lot of time doing that. If it's not infected, I will cement a shorter stem into that old cement mantle. So I've done that a number of times, and that can turn what would otherwise be a pretty hairy revision into a pretty straightforward revision case. So that's probably the only time I cement something. Even on reverses for fracture, I can't think of the last time I've cemented a stem in a fracture setting either.
Well, let's ask you both about stemless components. Tell us, what are the advantages? Dr. Sperling, let's start with you.
Yeah, so I think for me, stemless implants for me, the big advantage is if there's an option and an opportunity to save my patient's bone, I think it's something reasonable to pursue. So one is bone preservation. I think the track record of success If you look at many of the IDE studies, I know Mike was a part of a very large one, the largest one. I think that's been encouraging. I think it's frankly faster for me. I don't have to do all the circular reamers and broaches. Less blood loss, and I think a number of surgeons also say less pain because you're not violating the canal. So those are some of the reasons for stemless. I think that it makes it a very attractive option in my practice.
Dr. Wiater, how about you? Any additional thoughts? And if not, what are the potential disadvantages of stemless components?
Yeah, in terms of the advantage, I think John hit on all the major points, but there are a couple other, I would say that, the risk of an intraoperative fracture, like I talked about just a couple minutes ago, is much, much less with a stemless. Certainly, there's no risk of a humeral shaft intraoperative iatrogenic fracture like you would with a press-fit stem, so that's nice. There's also the less risk of, I think, stress shielding postoperatively, because that bone is getting loaded differently than a stemmed implant that has fixation distally, a diaphyseal fit, which is a pretty common mode of fixation for a lot of stems out there. So I think there's going to be less stress shielding seen. We're still early in the stemless experience, so we don't have any long-term data confirming that, but that's at least what we're seeing in the short term. I totally agree with Dr. Sperling that it is a faster surgery and less blood loss, and certainly the bone preservation is much greater. One final advantage is that there's no reliance on the humeral canals, so you're really free, I think, to do a better job replicating that patient's normal anatomy. So, with a stemmed implant, that stem really can only go in one place, down the canal. With a stemless implant, it doesn't really matter what the relationship with the metaphysis and the canal is. So I think it's a little bit easier to really, get the head position just right and replicate that patient's anatomy. And certainly in a malunion case, if you have a proximal humeral malunion or a malunion of the upper shaft, a stemless is a very nice way to go.
And Rachel, it's interesting. Oh, I'm sorry.
No, please go ahead.
It's interesting. I think you think of disadvantages. I'll just share with you. I remember when stemless first came out, what we were seeing, at least at Mayo Clinic, and the patients that I saw, was not the problems associated with implant loosening. It was almost exclusively cuff failure. Interesting. And I think I started understanding it when I started doing more stemless myself. And the problem we kept seeing was the humerus is heart-shaped. So it's wider up top, more narrow below. And there's a tendency for surgeons to put the stemless implant a little high on the humeral face because that's the widest part, because people want to avoid intraoperative fracture. But what was happening is we were seeing the humeral head then being placed too high with associated cuff failure. So I think the big thing for stemless that we've seen, and I've seen in my practice, is that if you do a stemless, paying close attention how much and in the direction you dial the humeral head down in relation to the tuberosity is critical. So soft tissue at the end, we've all learned that the anatomical shoulder in the end is a soft tissue operation. And with stemless, you can get yourself in trouble by placing the implant a little too high on the humeral cut and not being cognizant of the cuff in relation to the tuberosity.
This is something I want to really ask you guys about, because Dr. Wiater, you brought up the advantage of stemless is that you're free to the canal. The canal doesn't matter anymore. We can forget all those things we had to learn about posterior offset and medial offset, and the canal doesn't matter. Who cares? It doesn't matter. But one thing I want to ask you both is, for the lower volume surgeon or the trainee or someone who's maybe not as confident about their ability to replicate the anatomy as experts like you, both of you, is there an advantage to having the canal? Is there an advantage to having the canal to help to guide you to make sure that whatever you're doing is not crazy? So what are your thoughts on that? Is the stemless a good implant for someone who doesn't do as many implants? What do you think, Dr. Sperling?
So it's interesting. I think, again, I think since last October, I think I've done every anatomic, probably the last 90 anatomics I've done stemless, except one patient who wanted the identical side, the same implant. So I've used it, but I will tell you, Pete, I always use an extramedullary cutting guide. So the way I do it is I use an extramedullary cutting guide, bar down the forearm, 30 degrees of retroversion, 135 inclination. I actually pin the extramedullary guide with 2 pins to the humeral shaft, and I make the initial cut. And then what I do is I make a secondary cut to adapt that to the patient's individual anatomy. But I never do a freehand cut, actually, because I think you can get lost. And we've reviewed some series of people who made freehand cuts, and I think it can be hard, even in experienced hands. So I think you're right. Without the canal as a reference, I think it takes even more attention to detail to make sure that your cut is in the appropriate height, version, and inclination. And I'd love to hear Mike's experience, because Mike probably has more experience with stemless implants than anyone I know.
So I think, to answer the question about the canal, I think we're going to see that it's really going to depend upon a surgeon's training, because like Dr. Sperling, I haven't done a stem anatomic, in a long time, other than maybe in the last couple of years, one case or maybe two, where the bone was just so soft in metathesis, we had to use a short metathesis and had to use a short stem instead of a stemless. But almost exclusively for my primary anatomic total shoulders, they're stemless. So that's what the residents that we train at Beaumont are seeing. That's what our fellows that we train at Beaumont are seeing. And, by the end of their training, they got a pretty good experience with primary stemless arthroplasty. So for, somebody who trains like that, and I think there's other centers around besides Beaumont Mayo Clinic that provide that experience, like we see more and more surgeons where that's the way you do things. But for the surgeon who didn't get trained on stemless, I think there are some advantages to using the stem as a reference, particularly with the cutting guide. For the inexperienced surgeon or somebody who's just starting in stemless, I think using a cutting guide like Dr. Sperling suggested is a good idea. It is tricky to do a freehand cut. I personally do freehand cuts, but for somebody who's new in practice or trying it for the first time, I probably would recommend using the cutting guide, and then you can always take a second cut if you want to adjust it, as John said. One thing I see, consistently with poorly done stemless arthroplasties is a varus neck cut. So it's really important if you're going to do a freehand technique that you get the decent exposure, get all the osteophytes off, so you can kind of define that native anatomic neck. And it's the old orthopedic adage, measure twice and cut once. Really take your time and make sure you get it right, because it's easy to mess it up.
Yeah, I think I think what you both say about using the cutting guide is really good advice. We published that actually using my partner's patients, Dr. Robert Tajan, and compared to another surgeon that was not using a cutting guide, because he's been using an IM cutting guide. And at first, I have to admit I was a little bit like, why are you using the intramedullary cutting guide? You're using a stemless arthroplasty. This is like the exact opposite of what I thought we were supposed to be doing. But it leads to a better reconstruction. So I do think that's an important tip, for surgeons. If you're going to make this transition to stemless, if you're making a freehand cut, consider going back to using a cutting guide, whether it's IM or EM or whatever cutting guide you're using, to make sure that you feel a little more confident about the quality of reconstruction, because it's so important with stemless. The cut is so important.
Yeah, I think that's good advice. I think there's nothing wrong with, once you get your skills down and get your experience, then transitioning to the freehand technique. But I think in the beginning, using a cutting guide is a good idea.
So I think one thing I'd like to know, and I'm sure our listeners would like to know, for the standard primary total shoulder replacement case, does it matter? Is it okay for surgeons to pick either stemless or stemmed humeral component? Should we be all doing, a stemless? Because it seems like when you guys highlighted the advantages and disadvantages of both, it weighed in favor of stemless, if I heard correctly. Does it matter? Is it okay to pick either? Is one favorable for just the average primary arthroplasty case? Dr. Sperling, let's start with you.
I think it's interesting, Rachel. I think that over time that the advantages that we've seen have been published. So bone preservation, lower risk of intraoperative fracture, less blood loss, less pain. I think stemless, again, for me, is really preferable that way. The other thing I would say is the efficiency of the procedure. As a lot of us have transitioned to doing outpatient arthroplasty, and as Mike and I were talking about before the podcast, we have a lot of traveling nurses now at Mayo, and having one pan with simpler instrumentation for stemless is also a nice feature. So we put all of that together with great radiographic data. So I think that stemless is really, its time has come, and I think for me in my practice, it's become, the standard of what I do. There's nothing wrong with using a stem if that's what you're more comfortable with. It's just I've seen a number of advantages for stemless, very similar to what Mike outlined earlier. Love to get Mike's thoughts.
Yeah, good points, John. I think there's absolutely no shame in using a stemmed implant if that's what the surgeon is comfortable with. Like we talked about at the very beginning of this conversation, the results have been excellent, and we have results going back 50 years with stemmed humeral components and low complication rates. So there's absolutely nothing wrong with doing that. So it's all with what the surgeon's comfortable with doing and what is going to lead to the best outcomes in that individual's hands. If you look at what's published on stemless implants, and now we've got, there's quite a few studies, around the world, U.S. and in Europe. It started in Europe in, I think, 2004 and came to the U.S. about 2016 or so. A lot of published reports of stemless anatomic shoulder arthroplasty, and we've got 8 or so stemless reverse reports out of Europe. If you look at the clinical outcomes, despite all the advantages that we've talked about, bone preservation and so on, at the end of the day, the clinical outcome is as good as stemmed implants. So it's not inferior, but it's not a superior implant in terms of range of motion and radiographic complications like loosening or subsidence and patient outcome measures. So there's nothing wrong with doing a stemmed implant if that's a surgeon's preference, in my opinion.
Let's talk a little bit about component removal. Any component revisability is really critical. Have either of you removed many stemless components? How hard or easy were they to get out? Was there a lot of bone loss? Was there a big hole once you got it out? What do you think, Dr. Wiater?
So I have removed stemless implants. They are much easier to remove than a stemmed implant. I will say that. Most stemless implants are porous coated and really get outstanding ingrowth. So every one that I've taken out that's not loose has had a high percentage of bone ingrowth on the porous surface. You don't end up with a huge amount of bone loss. If you take your time, most of these implants are designed to be explantable. So they allow for, a thin osteotome and, curette or something like that to free up some of that bone porous metal interface. So if you take your time, you can take it out without removing much bone. And if you're impatient like me and you just kind of bang it out, you still end up with a situation where it's not difficult to put in a short stem humeral implant, as the revision.
Has that been your experience as well, Dr. Sperling?
It really has. I think that for me, the revision has definitely been easier, and I think it's refreshing. I have, some of the worst parts of my practice are removing, cemented stems, and the ability to be able to revise an uncemented stemless implant is so much better in that regard. So I think you're not sacrificing in terms of fixation. It's interesting. Just as a segue to that, I would say, Pete, a number of us are still like to do anatomic total shoulders in our practice, and even in expanded ages. So last week I did a stemless anatomic in an 83-year-old woman. She had a great quality cuff, minimal glenoid bone loss, and you put a stemless implant in there, you get great fixation, and over time you realize that you can get great fixation with these type of implants and the durability that's been shown in the literature. So I think we've expanded even our indications on stemless now, perhaps of what they were a few years ago. And it sounds like Mike's experience has been similar to mine, that over 98% of the anatomics he's doing now are stemless, similar to myself.
Now, both of you previously brought up stress shielding, and this is, I think, a super interesting topic. Historically, we've had problems, of course, with diaphyseal fixation stems, where you lose everything proximally. So I wanted to really compare to a more modern metaphyseal fixation stem. Do you think the earlier results show that Stemless has less stress shielding than a metaphyseally fixated short stem? What do you think the evidence shows? Is this better or not? What do you think, Dr. Sperling?
Yeah, I think so far the radiographic data looks very good. And I tried to look through the literature a short time ago, looking at it. And when you look at the radiographic studies on stemless implants in regard to stress shielding, I think they look good. There's some differences perhaps in different designs, but by and large, I think it's been very encouraging. Mike, what are your thoughts?
So, question is a shorter metaphyseal fixation stem compared to a stemless. I think they both have very low rates of stress shield. I actually don't know which one is better. I think, the long term we'll find out that the stemless is better, but we don't have a lot of good data literature on metaphyseal fixation stems. I think we know pretty well that a diaphyseal fixation stem is at risk for stress shielding. The metaphyseal is certainly a better option, but is it not as good or better than stemless? I guess I don't know the answer to that. I think they're both probably, very good in terms of stress shielding.
Let's talk a little bit about the subscap. When we go stemless, when you each go stemless, how do you manage the subscap? Let's start with you, Dr. Sperling.
Yeah, so I do a tenotomy, but I do a little different technique. So the way I do it is I always tenodese the biceps high in the groove. So if you tenodese the biceps high in the groove, you leave the biceps within the bicipital sheath. And then when you do your subscap repair, it allows for more robust subscap repair laterally. So I do a tenotomy, hemi-total reverse. It's the same technique, and it's the same type of repair. So tenotomy is what I prefer.
Dr. Wiater, how about you? How do you manage the subscap when you go stemless?
So I guess this is one area where John and I differ. So I do a lesser tuberosity osteotomy on my anatomics, and I do it whether it's a stemmed or a stemless implant. My reverses, I'll do a tenotomy just because it's quick and easy. And as you know, if the subscap doesn't heal, it doesn't heal well, it doesn't really impact function much. But certainly with an anatomic, it's critical. So I like the LTO because of the bone-to-bone healing. You have to be careful, using a stemless implant can kind of complicate an LTO. So you got to be careful to not take too much bone. It's not that difficult to get too aggressive with, your osteotome and go too deep or too broad. And then that can potentially compromise fixation of a stemless implant. So you got to, really take a thin piece of the tuberosity. I will use bone tunnels through the base of the bicipital groove, and then pass the sutures through the osteotomized neck of the humerus, and then the implant I use has the stemless implant has a collar with holes, so I'll pass the sutures through the holes of the implant so that I'm not relying solely on bone tunnels. It's kind of did the same thing with stemmed implants, where I'd pass the sutures through bone tunnels and then around the stem of the implant before we fully impacted it, so that if we lost fixation of the bone tunnel, we'd still have sutures around the implant. So that's been my technique with stemless humeral components for LTOs, and that's worked quite well.
I wanted to follow up on the LTO because I think a lot of surgeons use this technique, but may fall into that more aggressive category, and that obviously won't fly with a stemless. Any technical pearls you can offer, especially our young listeners, when performing an LTO with a stemless versus either a short stem or traditional stem?
Yeah, it's important to get a sense of the height of the lesser tuberosity. So I will kind of take a second to, outline the base of the bicipital groove, and then below the surgical neck with my cautery, and then I'll kind of palpate it and get a sense for how big it is, and they do vary in size. Some patients have bigger lesser tuberosities than others. And then I use a broad curved osteotome, and I start in the base of the bicipital groove. And if you have a large muscular patient, which is pretty common in an anatomic total shoulder, especially if you've got a male patient, it really helps to internally rotate the arm. And I'll sometimes take it out of the arm holder so I can really internally rotate it. And that way, you want to drop your hand with the osteotome so that you don't go too deep into the humerus, so that you take a thin slice of the tuberosity. So really internally rotating the arm will move the tuberosity away from the deltoid, which can, force your hand and force that osteotome too deep.
So that's, I think, great advice. Certainly that I think that has been a barrier for a small population for the transition to stemless. Certainly, I know it was some significant concern early on that I think a lot of people have overcome. I want to chat. We've talked a lot about stemless. Currently on the U.S. market, there are only stemless anatomics. There are, I think, at this point, one ongoing IDE and one IED about to start for stemless reverses. Certainly, there's a major regulatory burden that therefore to be overcome. But in the next few years, there will likely be stemless reverses on the market in the US. So I wanted to chat about specific concerns for stemless reverses. Do we need these implants to be different? Are there concerns about this working as well as stemless anatomic? What do you think, Dr. Wiater?
I think they're going to be fine. I haven't done any stemless reverses personally. I'm anxious to start doing them. If you look at the European experience, they do quite well. We actually, our group at Beaumont did a systematic review of the stemless reverse total shoulder literature we just published last year. And at this time, there's not many studies, but there are a handful of studies from Europe. And if you add up all the patients, there's 400 and something that have been reported on. The clinical outcomes are fine. They're as good as using a stem reverse implant. And similar to the experience with the anatomic stemless implants, the results of a stemless reverse implant in terms of humeral complications are about the same. So there's no increased incidence of osteolysis or loosening or failure related to humeral fixation. So I think they're going to be fine. I've been very impressed with the modern stemless implants that we have. Every time I do one on an anatomic total shoulder, I think to myself, man, I can't wait to do these on reverses because the fixation is so good. I don't really have any reservations to start doing those.
What are your thoughts, Dr. Sperling? Do you have any reservations or you have any concerns about stemless reverses? Is this something you think is coming soon, or we're going to have problems with this?
No, I agree with Mike. I'm encouraged by it. When I speak to my friends in Europe that have been doing this for a while, I think it's exactly what Mike said. I think the outcomes have been very good. I had a case today where I had a patient I was revising who had a plate in for post-traumatic arthritis and cup insufficiency. And I mean, boy, it would have been so nice just to take out the top 3 screws and put a stemless implant in there for reverse. And, I think that time will definitely come. And I agree with Mike. When it does get here, I think it'll be very similar to what we've seen on the anatomic side. It will likely be the go-to implant that we'll eventually use for reverse as well.
As we get toward the end of this podcast, because you guys have been so terrific covering, honestly, every component of these components, what does the future hold for the humeral component for both anatomic and reverse? Are we moving as a field to all stemless all the time, or will there always be a place for a stemmed component here and now? What do you think, Dr. Sperling?
It's a great question, Rachel. And I think my sense is that we really are heading towards stemless. I think that it's really being proven out now in terms of the studies, both on anatomic and what we're seeing in Europe on reverse, that it becomes a really good solution for patients, particularly when we think about what would the next operation be down the line for revision surgery. So the opportunity for bone preservation, ease of revision, and also, again, facilitating the transition to outpatient arthroplasty. There are a number of reasons to think why this is going to continue to expand, not only in anatomic, but in the future for reverse as well.
Dr. Wiater, what do you think? Is there going to be a role to have a backup tray whenever you're doing, an anatomic or in the future reverse and you're planning on using a stemless, but should we always have some sort of stemmed component available, or are we moving to an all stemless future?
So I agree totally with John that stemless is going to be the way of the future for anatomic and reverse. However, we will always have a need from time to time for a stemmed implant. So, you can do all the pre-op planning in the world and scrutinize x-rays and think, this is going to be great for stemless. We're all set to go. And then in the operating room, you may find that the bone quality is not good enough for a stemless implant. So it doesn't happen often, but it does. I'd say in the last, 2 or 3 years, I've had 1 or 2 cases where we made the humeral neck cut and it looks good, and then you kind of push on it and your thumb like falls through into wet yellow marrow fat, where there's just no bone below the humeral neck cut. And in that situation, you have, I guess you could try to cement a stemless implant, but that's, the best option would be to use a stemmed implant. So I think, unless you have a day in the OR where you've got a bunch of young males where the chance of that happening is about 0, but if you have, the average degenerative shoulder practice where you've got some older folks, especially older females, I think you really need to have a stem implant available, or else you could get yourself into a situation where, you're not going to have stable fixation. Again, that's exceedingly rare, but it does happen.
Yep, well stated, Mike. I agree.
I want to thank both of you for coming on. This has been a real tour de force discussing the ins and outs of, the future of the humeral component and what direction in which we're heading. It's been really refreshing to hear both of you talk so honestly about your experiences, and I know both of you have such a wealth of experience with shoulder arthroplasty. So this has been great. I really appreciate your time. I think listeners are going to love this.
Well, thank you, Peter. Thank you, Rachel. I appreciate it. And John, as always, I thoroughly enjoyed hearing you and learned a lot, as I do every time. So thanks very much. My pleasure to be here.
Rachel and Pete, thanks so much for the chance to be here. And Mike, as always, really enjoyed chatting about shoulder arthroplasty with you, and really enjoyed the discussion tonight. Thanks so much.
And I'll echo Pete. I want to thank both of you for taking the time to spend with us and with our listeners. This was truly very educational, and I really enjoyed it myself. I know our listeners will. That is all the time we have for today's podcast. Again, we want to thank our guests so much for spending the time with us. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.